Good morning, everybody. What an exciting panel to be a part of this morning. What an exciting new addition to our program, to our academic program. So yes, I'm going to take you through a cook's tour through some of the gadgetry that we have to add as endoscopists, as medical gastroenterologists to the management of this very difficult disorders, these very difficult disorders that we have with obesity. So as Fazana already mentioned, we have this big gap that we have to try and bridge. We have lifestyle modifications, therapeutic lifestyle modifications that we know as we advise patients on the best in terms of diet, exercise, and behavioral change. At best that we can hope for is about a 3 to 5% total body weight loss. If we combine that with the medications that we've spoken about, maybe we push that up to about 8 to 10%. The problem with that is that we can't really maintain this weight loss beyond about the 24-month mark, and certainly not maintained beyond about 5 years. These patients have a high rate of recidivism, which means that they regain the weight that they've lost, and those that may maintain their weight loss have to be on these medications long term. We have this major issue with patients who are obese and are also diabetic, who have this issue of also being unable to maintain their glycemic targets as well. So you have patients who are obese who can't lose weight and who are diabetic who can't maintain their glycemic control. And that has led us to actually jumping from medical therapy all the way to bariatric surgery. And these bariatric surgical interventions are very effective. They've led to total body weight losses of up to 40%. And these body weight losses are actually very well maintained. Patients lose weight. They manage to, even reverse their metabolic complications. They even go into remission in terms of their diabetes. But there are certain limitations in terms of bariatric surgery, which I'll also get into a little bit later. So in terms of bariatric surgical procedures, we know, and it's established, we've got good data that they're superior to, lifestyle modifications and pharmacotherapy alone, whether it's, surgical procedures like reducing the fundus and the gastric body by doing a gastric sleeve. And these procedures are now being done as a gold standard internationally as laparoscopic procedures and no longer as open procedures, whether it is a sleeve or a fundoplication that we can do as well with sutures. These are also done by the surgeon. These procedures are going to achieve our patients' weight loss targets. They're going to maintain the weight off long term, and they're going to also achieve the glycemic control in our diabetics. And that's what we're looking for in our patients. And we know that they're the gold standard therapy that we have at the moment, most effective, durable therapies that we have for obese patients with type 2 diabetics. They're currently mostly only indicated for patients or accessible mostly to patients that have a BMI of over 40. For the lower BMI categories, it will be patients that have comorbidities or metabolic complications. We know that in our settings, even internationally, these are specialized therapies, these are specialized surgeries. They are also associated with a lot of comorbidities. These are permanent procedures that are irreversible, and they're not accessible to all patients. We're also dealing with a subset of patients that tend to have comorbidities that may not be the best anesthetic risk profile of patients, and they therefore may not be a surgical candidate. And so these patients may not, in fact, be able to undergo these bariatric procedures. So enter then the endoscopic therapeutic procedures that have sort of come up in the last sort of 10 to 20 years to try and bridge this therapeutic gap. These procedures are minimally invasive. They can be done by your average gastroenterologist, very minimal in terms of the learning gap and the learning curve to perform. They try and emulate the same anatomical and physiological changes that the surgical procedures would effect in the upper GI tract in terms of bringing about weight loss, whether that is taking up or reducing the gastric lumen space by taking up space with the balloon, devices like intragastric balloons, or even reducing the gastric lumen itself by opposing the mucosa with gastric fundoplication that can be done endoscopically with the endoscopic sleeve gastrectomy. And I'll go into detail with each of these procedures and talk you through some of their benefits and some of their adverse effects as well. Patients can have these procedures done endoscopically as a day procedure, which means that they can for the most part, be done under conscious sedation. This saves our patients long anesthetic exposure. They also provide an alternative or a bridging therapy for those patients who are non-surgical or who are poor anesthetic candidates. They tend to have a lower mortality and complication rate compared to the surgical procedures. And for the most part, these procedures are reversible. So should there be a reason to reverse a procedure, or should a patient, for example, suffer a morbidity or a complication, you can easily remove a balloon or even undo some of the sleeve gastrectomy or gastroplasty procedures that we can do endoscopically. So what are the mechanisms that we actually employ when we try and perform these endoscopic bariatric procedures? So essentially we are acting in the upper GI tract, so it's going to be at the level of the stomach or the level of the small bowel. And at the level of the stomach, we're looking at restricting the volume of the gastric lumen itself. So we're reducing the reservoir of the fundus and of the actual gastric body of the stomach itself. And this allows us to limit caloric intake for the patient. The patient feels fuller for longer, has prolonged or sustained satiation because of slowed gastric emptying as well. We can also deploy devices in the distal stomach as well that can produce a partial or intermittent gastric outlet obstruction. Again, slowing gastric emptying, allowing your patient to feel fuller for longer. And there's also the benefit of reducing the production of ghrelin. Ghrelin is your appetite stimulating hormone, and therefore that is produced predominantly in the fundus of the stomach and some a little bit in the corpus as well. And if you reduce ghrelin production, your patient doesn't have the drive to continue eating in terms of volume. And if we look at small bowel procedures, these are going to produce a malabsorptive component to your bariatric procedures. We are trying to bypass the foregut. Remember that when we do this, the bariatric surgical procedures, whether it's a Roux-en-Y or it's a biliopancreatic procedure, we are trying to bypass nutrient contact with the foregut, with the duodenum and the proximal jejunum. We're reducing that absorption of nutrients by the small bowel as well, by shortening the length of the small intestine and delivering that nutrient bulk to the distal small bowel. We've also in the latter years have learned about the neurohormonal response that deferring or bypassing the foregut can create. And I'm going to talk about in detail the foregut and the hindgut hypothesis and how we can actually improve or even recover the incretin effect that can be blunted in our patients that are obese and diabetic, and therefore not only produce loss of weight, but also improve glycemic control. So what are the gadgets that we're talking about? So we'll start first in the stomach. As I mentioned, we're going to be restricting gastric volume. So these can be either space occupying or non-space occupying procedures. The space occupying devices for the most part are going to be balloon, intragastric balloons, and they are varying types. They can be filled with saline or filled with air that are going to actually take up volume in the stomach and reduce the space you have for caloric intake. We can also have gastric remodeling procedures, which means that you reduce the size of the stomach, similar to what you would do in a laparoscopic sleeve gastrectomy. So you're doing a gastroplasty and reducing the fundus and the gastric corpus size as well. You also have the option of reducing already calories that have been taken in by the patient from being absorbed by removing them after a meal. And this is a procedure called aspiration. So a patient who's taking in a meal 20 to 30 minutes after eating will then aspirate out gastric contents, preventing absorption of excess calories. And then we have the possibility of actually putting in procedures or putting in devices that can block the passage of contents from the stomach in the distal, in the sort of the pylorus, into the duodenum, and actually cause partial gastric outlet obstruction, slowing down that gastric emptying and leading to the patient feeling fuller for longer. So let's start with the most common and readily available procedure that we can perform. And these are intragastric balloons. You may have heard about these. What it really entails is that we go in endoscopically with a catheter and a balloon that is attached to the end of the catheter. The balloon is inserted, initially deflated. We then insufflate this within the stomach with saline. The saline can be anywhere between 450 to 700 mils, depending on what you're trying to achieve or the volume of the stomach that you're trying to occlude. And usually the saline can also be injected with methylene blue that allows for the patient to be alerted to any leaks of the balloon itself, which means that the methylene blue, when it's absorbed and it's excreted renally, the patient will be aware of a color change in their urine. And it's usually a disturbing bright green urine that they will pass. And you want them to be aware of any balloon leaks, because should this balloon leak and then pass down the stomach, it can lead to problems with small bowel obstruction. But for the most part, they're very durable and they have very few leaks that the patient will experience. There are now newer balloons that are now filled with, or can be filled with, air instead of saline, and these can be tolerated a little bit better than the patients than the balloons that are filled with air. There are also novel newer balloons that are coming out now that are actually placed without the endoscope, which means that the patient can actually just swallow a little tablet, and so it's placed like you would an NG tube. The balloon is within this capsule here, and this capsule is actually sensitive to gastric pH. And so when it arrives within the stomach, this capsule disintegrates and releases a deflated balloon. You then would insufflate the balloon on the outside of the patient with some saline. And then once the balloon is fully insufflated, and this is done under fluoroscopic surveillance, so you would need screening for this. Once the balloon is fully insufflated, the port here actually changes shape, which allows the actual catheter to disconnect from the balloon, leaving the balloon intact. You would leave a balloon in situ for the patient for about 6 months. After 6 months, you must go in endoscopically and retrieve the balloon, at which point you would just sort of, remove the water from or the saline from the balloon and retrieve the deflated balloon. It is currently FDA approved in the States for class 1 and class 2 diabetes. And the only contraindications that really exist is patients who've had any previous sort of gastric surgery and patients with large hiatus hernias, because those are patients that are likely to perforate with these balloons as well. So looking at the pivotal studies, do they actually work? So the Obera balloon is the oldest balloon that we sort of had from about 1992, but this pivotal study came out in 2012. And what they did is they sort of compared patients who had the best sort of observed lifestyle changes compared to patients who had lifestyle changes plus the Obera balloon. And if you look at patients who had just the lifestyle changes, they had an average percent total body weight loss of about 3%, whereas the Obera balloon patients lost about 10%. And you can see that some of the other balloons as well that have since come out have also demonstrated a much more robust sort of total body weight loss than we see with just lifestyle changes alone, and even with just medications that we see with patients in pharmacotherapy. What are some of the adverse events that are expected with intragastric balloons? There are very common early adverse events. Patients will complain of abdominal pain and nausea. And about 10% of patients don't tolerate the balloon at all, and this leads to early removal. The abdominal pain and nausea is usually mild, managed with medical therapy, and usually does not result in patients needing to stay longer in the hospital. It can be managed as an outpatient with just medical therapy. And the serious adverse events were still very low at about 1.4%. So not very many patients actually had any serious side effects. In terms of limitations of balloon use, the weight loss in terms of actually the outcomes. So at 6 months, the weight loss was definitely sustained. At 12 months as well, we still see that 8 to 10% total body weight loss being maintained. However, once the balloon has been removed, past that 12-month period, we do start seeing recidivism. We do start seeing patients start to gain weight. And at about 5 years, only 20% of these patients maintain the total body weight loss. That means that you've essentially lost most of sort of the benefit that you've gained from that the balloon. There have been studies that have looked at reusing or replacing the balloon, and you can get some benefit from replacing the balloon. It's not as robust, and they do suggest that if you are going to replace the balloon, to give the patient a balloon-free period of a minimum of 3 months. In terms of long-term data that we have for these patients, because the balloon has been in use now for quite a number of years, there has been this meta-analysis that looked at 10 randomized controlled trials and over 30 observational studies. So we've got data for over 5,000 patients now. And they looked as well in terms of the effect on obesity-related comorbidities. Because you don't want patients to just lose weight. You want to look at what's actually happening with their comorbidities as well. Overall, in this meta-analysis, they managed to see that these patients within 6 months have managed to reduce their HbA1c by 1.1%. And these are patients who have kept their medical therapy the same, but they did insist on them continuing their lifestyle modifications. They also did see clinically significant improvements in their fasting blood glucose and their lipid profiles, as well as blood pressure indices, as well as the ALT in all of the patients with, in some of the patients with NAFLD as well. In terms of adverse events, in terms of adverse events, they were still very low. Out of 5,000 patients, there were only 5 patients who experienced gastric perforations and only 2 deaths. So if you compare that to patients with bariatric surgery, you can see that the incidences of adverse events are much lower. These intragastric balloons are quite safe. If you are able to use these patients or bridge these patients for 6 months and actually manage to achieve some of your metabolic comorbidity reversals, that can be of benefit to your patients. And this can be used as well as a bridging for patients who may initially not be surgical candidates, as a way to get them to be a better surgical, to improve their profile, to be a better surgical candidate for definitive therapy like bariatric surgery. However, in your patients who are in the lower sort of obesity category, this improvement in their total body weight and in their profile might be enough to keep them from progressing with their comorbidities as well. So what about reducing gastric size and gastric remodeling? So we know we have very good data for gastric sleeve gastrectomy or laparoscopic gastric sleeve gastrectomy. So we are trying to remodel the stomach here to emulate the same effects that a gastrectomy would do. And we are opposing the anterior and posterior walls by either using a suture or using a stapling technique. And if you look in this picture here, what we're doing is actually going distally here in the pylorus and putting sutures along from the anterior wall down into the posterior wall and then moving proximally. And the idea is that you reduce from distally proximally, and you'll reduce the volume of the stomach by 75 to 80% of its original size. And you can do this either by opposing mucosa to mucosa or by using a full thickness plication to oppose serosa to serosa. And the benefit of reducing serosa to serosa as opposed to mucosa is that it might be a little bit more durable longer term, because the sutures within the mucosa may actually, with tissue overgrowth, may in fact come apart over some time. So in terms of benefits, it also does result in slowing gastric emptying, and obviously reduces the total caloric intake that your patient is able to take in. With the sleeve gastrectomy, because you're actually removing gastric tissue, we see much further drops with ghrelin production. That hasn't been seen as robustly with endoscopic gastroplasty. So you don't have that hormonal benefit with the endoscopic procedure as you would with the surgical procedure. So in terms of the data that we've seen now with these patients, in terms of the weight loss and whether this is sustained, and how much weight do they actually lose. As I was mentioning, this is a novel procedure, and there have been multiple sort of stitch patterns that have been suggested, but it's been sort of adopted now to do the U-stitch pattern. And this was the biggest sort of trial that has been published, multi-center trial, prospective trial that was published using this U-stitch pattern that's been adopted by multiple centers now. Small numbers still because of how new and sort of, this procedure is. 193 patients, all of them were overweight and obese of different categories. And they looked at these patients over 6 months, 12 months, and up to a year. And they were looking at the primary endpoint of total weight loss. And they were looking at least a total weight loss of 10% or more. And then they were reporting on immediate and delayed adverse events. And as you can see, that across all the obesity categories, from overweight to obese class 3, all patients within 6 months lost a minimum of 10% of total body weight. And this was sustained at 1 year as well. So this is a procedure that can be carried out for patients that are within that overweight category with lower BMIs, all the way to the super obese, the patients that have BMIs of 40 to 50. And all those patients will experience a significant total weight loss, and very quickly within 6 months. And the severe or serious adverse events were also quite low, only 1% in that 103 patient group. And 2 patients experienced perigastric collections that required pigtailing, and 1 patient required surgery to drain that perigastric collection. So in conclusion, it was a safe and effective procedure for overweight to obese category 3 patients. And it was durable, seen, and these total weight loss was seen all the way up until 1 year. There is a concern about durability of sutures beyond 12 months. That's why there's this new procedure now that is being sort of developed to do this serosa to serosa opposition, as opposed to the mucosa to mucosa opposition, because mucosa does heal much better than the serosa, and there is overgrowth of the sutures, and sometimes the sutures do unfortunately come apart, and the patients do then regain some of the stomach volume. So in terms of metabolic complications in patients who have undergone a sleeve gastroplasty, so one of these sort of prospective groups did do a subgroup analysis to look at what happened within the patients that did have metabolic complications. They looked at their patients. There were 53 patients at 12 months after the gastroplasty, and they looked at changes in the HbA1c. Mean HbA1c wasn't terrible, but 6.6 mean HbA1c, but significant change after the sleeve gastroplasty, with no changes again in medical therapy. Reduction in waist circumference, in blood pressure indices, LDL, as well as ALT. And they did also look at objective measures of steatosis, and those were also seen to reverse. So as a minimally invasive and minimally invasive procedure, it was effective, it was safe, and it was also maintained up to 24 months. And we are waiting for data up to 5 years now for this cohort of patients that have been reported on as well. So the next procedure I'd like to talk about is gastric aspiration therapy, which is a little bit of a controversial procedure. What it is essentially a modified PEG device, which we put in the stomach. It consists of a fenestrated tube that sits within the corpus up into the fundus, and with an external port that sits just below the surface of the stomach. There's an open port that allows the patient to then connect to it and aspirate gastric contents. So 20 to 30 minutes after having a meal, the patient then drains about a third of the calories they've taken in. They can also use a pump, which then sort of irrigates water into the stomach and pumps out some of the gastric content as well to facilitate this aspiration process. Also, obviously, concern about eating disorders and potentially, facilitating patients even sort of pumping out more than a third of their caloric intake. But these devices have actually been loaded on with a lockout system, and patients obviously then also measure the caloric volume that they've taken in and how much they need to pump out afterwards. The FDA has approved this since 2016, and it is approved for patients that have a BMI of more than 35. In terms of adverse outcomes, only one patient was reported in the pivotal study to have a persistent fistula that required closure. That patient did require surgery to close the fistula down, but they haven't been, from some of the concerns about eating disorders and electrolyte abnormalities from this irrigation and pumping out, no major electrolyte abnormalities or eating disorders, and there have been some improvements in the metabolic comorbidities. In terms of total weight loss, some significant total weight loss that has been seen at 12 months, and some of these patients have actually maintained some of this weight loss throughout the 4-year follow-up, but again, small numbers. Some patients were lost to follow-up as well. Some patients removed the aspiration device after the first year. Not really the definitive therapy you'd want for a patient who's otherwise able to undergo surgery. Can also be used for as a bridging endoscopic procedure for a patient perhaps who would want to optimize their metabolic profile before referring them for a definitive surgery. But certainly one of the options that we have available to us, or we could have available to us in the future as well. And then something that's new as well, that's not yet commercially available, something called the Transpyloric shuttle, which essentially is a procedure that we can use to cause an intermittent gastric outlet obstruction. So it is a gadget that sits, we deliver it in the stomach endoscopically, we leave it in the distal stomach into the antrum, and with peristalsis, it eventually will come and sit with the larger spherical portion sitting in the pylorus, and then with the smaller spherical portion sitting in the duodenum. And what it does is intermittently, it will come in and out and sort of close off the pyloric channel and allow for slowed gastric emptying and partial gastric outlet obstruction, and decrease your caloric intake as well. You can leave this in for 3 to 6 months. You already see total body weight loss at 3 months already, but recommended to leave it for 6 months, similar to the intragastric balloon. And in the pilot study that has been published in 2017, there were 20 patients that this transpyloric shuttle was applied in, and in those patients, they did see excess weight loss at 3 and 6 months of about 31%, and at 6 months up to 50%, so quite robust weight loss. But there were some issues with some nausea and vomiting initially, but that did resolve over a couple of weeks. And some patients there were 2 patients that did have to have it removed because of gastric ulceration. It's not currently in commercial use, it's currently being looked at. There's some issues as well in terms of the actual device itself and sitting within the pyloric channel reliably. So this is not currently available, but something to look forward to in the future. So what about endoscopic bariatric procedures and the small bowel? And this is an interesting sort of area for endoscopic procedures in general. So we've learned a lot in terms of the metabolic function of the foregut. And some of this information came at looking at patients who have had bypass surgeries or endoscopic or surgical bariatric surgery or procedures, and what happened with their homeostasis, for their glucose management or the glycemic control post-surgery. And this allowed us to come up with the foregut and the hindgut hypothesis. And of course, we know as well about the incretin effect that Fazana spoke about earlier. What is the foregut and the hindgut hypothesis? So with the foregut, we know that the proximal small bowel, the duodenum, is where we have a lot of enteroendocrine hormones being produced in the enterocyte brush border. And we know that in the proximal small bowel, we have what is yet to be identified as the anti-incretin substance that is being produced. And the incretin substance, or the GLP-1 producing cells, have a higher concentration lower down in the distal small bowel. So in the distal jejunum, ileum, and even in the colon. So any sort of caloric intake or caloric delivery to the foregut may stimulate more of an anti-incretin effect as opposed to an incretin effect. So bypassing the foregut and allowing caloric delivery and nutrient stream from the stomach straight into the distal small bowel, so into the ileum and then into the colon, will allow you to then stimulate the production of GLP-1, so stimulate the incretin effect and down-regulate the anti-incretin production. So this would allow then for you to access improved GLP-1 function, so increased GLP-1 production, which we know has all of these extra effects, not just on homeostasis, on glycemic homeostasis, but also on satiety in terms of appetite. It crosses the blood-brain barrier and reduces appetite, so your patients eat less. It also affects gastric emptying, so your patient may have reduced caloric intake from there, and obviously all of your improved endocrine effects as well. So we know that causing bypass in your patient is not just a means of improving weight loss, it's a means of controlling metabolic glucose or glycemic control. And your glucose homeostasis improves by just bypassing the foregut. So we try endoscopically then to mimic foregut diversion by producing bariatric devices or endoscopic bariatric procedures to try and mimic these, something like a Roux-en-Y bypass, to try and limit any nutrient content with the proximal duodenum. And we know that in the diabetic patient, a healthy patient who has a normal incretin response to a small bowel delivery of nutrients or glucose, in the diabetic patient, the incretin effect is very blunted or maybe very reduced. So if we can actually improve this GLP-1 production from the distal small bowel and the ileum, then we may potentially recover this incretin effect and improve glycemic control in our patients with less requirement for oral or even insulin use in terms of medications. We also know that bile acids also stimulate GLP-1 production, So if we are able to also improve delivery of bile acids by increasing intestinal transit by causing bypass, we also can stimulate or access this GLP-1 production as well in the distal ileum. So overall, foregut, diverting from the foregut allows you to achieve weight loss as well as improve glycemic control for your patients, which is beneficial, even in your patients that are not obese, but that are struggling to achieve their glycemic control. Just being able to achieve some of these endoscopic small bowel bariatric procedures may assist them in improving their glycemic, or at least attaining their glycemic targets. So what are some of these small bowel procedures that we're able to do? So we know that we are able to actually deploy a bypass sleeve, which essentially is an impermeable sort of silicone sleeve that covers the duodenal surface that allows for food that has come into the stomach, we don't reduce the stomach size in any way, to then pass through the sleeve and bypass the entire duodenum and be delivered into the jejunum. And that allows for the GLP-1 stimulus in the distal jejunum and ileum, and avoids that foregut stimulus of the anti-incretin effect. We also can then stimulate that Roux-en-Y bypass by even bypassing the stomach itself. So by causing a duodenal and jejunal bypass. So we can have food coming straight from the esophagus into a sleeve that bypasses the stomach, the duodenum, and gets delivered directly into the jejunum, and also will then have the benefit of reducing ghrelin production potentially, but also then stimulating that incretin effect as well. We can also cause essentially an iatrogenic fistula, where we cause a connection between a proximal small bowel and distal small bowel, which will allow some of the food to still progress along the normal pathway, and some of the nutrient content will take a shortcut down from the proximal small bowel straight down into the distal small bowel, again bypassing the rest of the small bowel as well. We also have this novel procedure called the duodenal resurfacing, mucosal resurfacing, which I'll talk about just now as well. So in terms of the duodenal bypass liner, and these are also still very new procedures, they've been only trialed on very few patients. We've got the endoluminal bypass sleeve that I've spoken about now, which causes a gastroduodenal jejunal bypass, bypasses the entire stomach and the small bowel, has been piloted on 12 patients with robust excess weight loss at 1 year. 6 patients lost about half of their excess weight loss. The only problem is keeping this cuff in this distal esophagus and not actually having any leaks around here. And so some of the patients that didn't see some of that weight loss actually had some leakage of the cuff around the actual device itself. And so the sleeve is currently being optimized to try and keep this in situ as well. And then in terms of the endobarrier, my apologies. The endobarrier, or the duodenal bypass sleeve. This is the sleeve that sits in the duodenal bulb. So this doesn't bypass the stomach, only the duodenum into the jejunum. So you cover the proximal duodenum and the proximal jejunum, and you deliver the nutrient mass into the jejunum. Into the jejunum. And it also affects and stimulates GLP-1 production from the distal jejunum as well. Piloted in 151 patients. Unfortunately, despite the fact that some of the patients did have weight loss and it did reach its endpoint, they had to terminate this procedure early, or this trial early, because unfortunately about 5 of their patients did develop hepatic abscesses. And so this device is currently undergoing a redesign to see if they can maybe fenestrate it, or see what the possible issues could be in the design that caused those hepatic abscesses. So this exciting procedure called the duodenal mucosal resurfacing, which is sort of the new kid on the block in terms of metabolic control of patients, something that's been looked at as well in terms of non-obese patients and glycemic control for patients who are not hitting their glycemic targets, but also obviously for the patients that are obese as well and trying to lose weight. So what does it entail? It entails basically causing intentional thermal injury to the duodenal mucosa. Here we put down an endoscope. The endoscope has a gadget at the end of it that has a balloon with an injector as well at the end of it. We inject the submucosa with some saline bleb so that you limit thermal injury to the actual duodenal wall. And then this balloon is inflated with water. The water is heated to about 90 degrees Celsius. And then there's a sort of circumferential thermal burn that is applied to the mucosa itself. And we apply this mucosal burn along about 60 centimeters of small bowel from the ligament of, from the ampulla to the ligament of Treitz. And the idea is that once you've caused this ligament, this inflammation, and you've caused the mucosal injury, the mucosa will eventually restore. And hopefully that diseased mucosa in a diabetic patient will then restore with normal new enterocytes that will have normal signaling and normal enterohormonal cells that will hopefully have an improved or normal incretin effect, and not this abnormal blunted diabetogenic hormonal effect. So again, like I mentioned, being mentioned for patients who have poorly controlled diabetes, even in the absence of obesity. So this is a study that was sort of looked at in terms of the effect of patients who actually underwent endoscopic duodenal mucosal resurfacing, looking at them after 1 year and looking at their metabolic complications and what happened to these patients at follow-up. So in terms of the patient profile, again, we're looking at not very sort of big numbers. We're looking at less than 50 patients here. But if you look at the patients before, these were patients that had a BMI of about 30 or more. So some of these patients were again diabetic, but not necessarily diabetic, and in the lower classes of the obese category, had HbA1cs of around 8.6 before the mucosal resurfacing was actually performed. And these patients were already on medical therapy. They'd failed lifestyle management, and they were failing oral anti-diabetic medications to obtain their diabetic targets. So they kept these patients on stable therapies for at least 6 months while they passed the point of doing the mucosal resurfacing. And then they followed them up and watched what happened with the mean, with the HbA1cs and other sort of metabolic targets as well. So in terms of the mean HbA1c, they actually saw a change in the mean HbA1c of between 0.9 and 1%. And this was maintained all the way up to the 12-month point. So initially after the 24 weeks, which was the initial 6 months. So within 6 months, patients had a change in the HbA1c of at least 0.9 to 1% with no change in their medical therapy at all. The weight difference or the change in weight was moderate. They only saw the biggest change was sort of after 4 weeks, and then it sort of plateaued out, but was still maintained at 6 months and even up to 12 months. There was also improvement in the insulin resistance in the HOMA indices, and they also saw a change in the plasma glucose as well as the ALT. Again, there were also, I didn't include it here, but there were objective measures of steatosis, and those also reversed even with in these patients as well over the 6 months and 12-month follow-up as well. So in conclusion, in terms of the stepwise approach and the therapeutic gap that Fazana mentioned earlier, in terms of the novel medical therapies that are coming out, there absolutely is a role for them. But we know with medical therapy, we're looking at, maximum 10 to 15% of total body weight loss. So there's certainly the space there for endoscopic therapy. We're going to bridge this gap by introducing these endoscopic bariatric and metabolic procedures, especially for patients that are maybe at lower categories, who maybe have comorbidities, particularly those with type 2 diabetes in the case of duodenal mucosal resurfacing and non-alcoholic fatty liver disease as well, particularly for the patients with non-alcoholic fatty liver disease. I know it was mentioned a little bit earlier, and I wanted to also, yes, confirm what Fazana did say. We do see a reversal of steatosis when patients do lose about 5% of total body weight loss, but we do need for patients to lose at least 8 to 10% of their total body weight. The reason is because most of the time these patients have established fibrosis. They also generally have comorbidities, things like ASH on top of the NASH as well, and steatohepatitis. They also tend to have biliary problems from gallstone disease. They may have viral hepatitis, any other comorbidities. So we tend to see that these patients generally have progressed on from just having steatosis, and they may have fibrosis. So we definitely need to see a sustained and a prolonged, maintained weight loss to have a definite benefit in the NAFLD profile. For patients who a BMI of above 40 that are poor surgical candidates who cannot access bariatric surgery and who cannot have or maintain weight loss with medical therapy alone. These patients need some sort of bridging procedure. Endoscopic therapies are where we can actually help these patients out as well, perhaps even improving their profile to make them surgical candidates in the long term. They're effective. They're less invasive and they're safer than surgeries. They're reversible in some instances, and we don't see the same metabolic and nutritional complications long-term that we see with some of our surgical procedures. They potentially have better access than surgery. These procedures can be done in endoscopic environment as a day procedure, and potentially in a population-based approach, these are going to have much better access than surgery that has to be done at high volume centers in the hands of a specialized surgeon that may not be available everywhere. Again, we can maybe look at doing combination or even staged procedures in the future, maybe starting off a patient with endoscopic therapy and seeing if they're going to be part of that group of patients who do maintain long-term body weight loss and do not need to go on to bariatric surgery. Or maybe they do, need to then, have duodenal mucosal resection and then move on to having a more definitive procedure after that. Thank you.